Okay, good evening, everyone. We're going to discuss today mitral valve disease. What about the pediatric population? Okay, so as I was saying, we're going to discuss today mitral valve disease about the pediatric population. First of all, we're going to discuss the normal mitral valve anatomy. As we all know, we have the anterior mitral leaflet and the posterior mitral leaflet. We have the commissures, the anterolateral commissure and the posteromedial commissure. You can see here this again, the anterior mitral in proximally to the aorta, and the posterior mitral leaflet with the scallops A1, A2, A3, P1, P2, P3. Okay, then we have also the anterior annulus, the posterior annulus, the chordae tendineae, and the papillary muscle, the lateral papillary muscle, and the medial papillary muscle. Some echo landmarks, okay, as you see here, the mitral valve, the anterior leaflet, as we were saying before, the aorta, which is proximal to the anterior leaflet, and laterally we have the left atrial appendage. So to have a good idea about the mitral valve, we need, of course, which is the most important tool, which is echo. Transthoracic echo is important, and 3D echo is also very interesting in these cases. So mitral valve disease and some echo findings. When we talk about mitral valve disease, we talk mostly about mitral stenosis and mitral regurgitation. We need to see the thickening and deformed leaflets, the Doppler gradient, and the associated findings in mitral stenosis, like left atrial enlargement, right ventricular hypertrophy, pulmonary hypertension, and of course the LV function. In mitral regurgitation, we need to determine the etiology, to see the leaflets, the chordae, to see if we have any mitral valve prolapse or any possible ischemia that provoked the mitral regurgitation, and of course the LV function. Some pathophysiology of the congenital mitral valve disease normally is due to the malformation of the mitral valve apparatus, which result in mitral stenosis, regurgitation, or both. Then this significant flow obstruction or regurgitation may result in elevation of pulmonary venous pressures, and with time we will have right ventricular hypertrophy and even right heart failure. Okay, some patterns of the congenital mitral valve disease. Mostly mitral stenosis, sometimes it is isolated in 25% of patients and could be associated with other anomalies. In 40%, it is associated with LVOT obstruction. Okay, so signs and symptoms in mitral stenosis, in congenital mitral stenosis, it is usually severe, and if it is untreated, death during the first 4 to 5 years of life. For the mitral regurgitation patients, often it is only moderate in severity in early life, and to operate these patients, we can wait until older ages, more than 5 years. Okay, so we need to see, most commonly, we need to see the mitral valve anomalies, which include the thickening and the stiffness of the leaflets. We need to see the fusion of the commissures. We're gonna see some examples now. And we need to see the anatomy and the anomalies of the chordae tendineae, and of course, the heart tissue, and also the number of opening of the mitral valve. We can have, for example, a double orifice mitral valve. We're gonna discuss this later. Okay, first we're gonna discuss the mitral stenosis. We have several etiologies of mitral stenosis. Most commonly in the pediatric population, it is rheumatic or congenital. We have some genetic syndromes like the Hurler syndrome, which is a mucopolysaccharidose syndrome. Okay, it could be drug-induced. In drug-induced, we have also a thickening of the mitral valve. Could be due to a carcinoid syndrome, and of course, in older ages, due to a prosthesis valve stenosis due to calcification. And also, we have a physiological mitral stenosis in case of left atrial myxomas. So we're gonna differentiate two most important pathologies in the pediatric population, which is the rheumatic mitral stenosis and the congenital one. And most important to differentiate both of them, it is the fusion of the commissures, which is most prominent in the rheumatic mitral stenosis. Okay, we can also see in rheumatic mitral stenosis some calcification of the leaflets and commissures with a restriction of the leaflets anatomy and mobility. So the congenital mitral stenosis, we have several types. We're gonna divide them to three types: the supravalvular, the valvular, and the subvalvular. The supravalvular, when we have a fibrous ring, and like in Schoen's syndrome, the valvular, when we have a fusion of the commissures and papillary muscle, like in rheumatic mitral disease. And when we have a double orifice mitral stenosis, excessive valve tissue, and annular hypoplasia, which is mostly associated with the hypoplastic left heart syndrome. And in the subvalvular population, the single papillary muscle, like in parachute valve, mitral valve, the abnormalities of large or numerous papillary muscle in the hammock valve, and the absent papillary muscle. These subvalvular anomalies are associated with other anomalies, and most importantly with LVOT obstruction, like in systolic anterior motion in hypertrophic cardiomyopathy. Okay, so this is a typical congenital MS. Here we have the hypoplastic type. Here we have the supramitral ring and the parachute mitral valve with a single papillary muscle. The supravalvular mitral stenosis and a fibrous ring. This is, as we see here, it is a case, it's a clinical case of a patient. If you can see here on the TEE, we can see here the mitral ring and here the aliasing of the Doppler tissue, very important aliasing, okay? And if you see here more, we can watch the aorta. We can see a subaortic obstruction with an aliasing, which is an association, an important association of mitral ring and a subvalvular aortic stenosis in Schoen's syndrome. Okay, and here 3D echo can give us a more important view of this fibrous ring. Okay, and of course, the mitral valve gradient, which is very high in this case. Okay, so the supravalvular mitral ring, it's a fibrous membrane located at the atrial surface of the mitral valve. It is difficult to see on transthoracic echo. Transesophageal echo remain the most important method of choice for this diagnosis. And when it is attached to the atrial surface, like in here, it is attached to the atrial surface, this ring is an intramitral ring. When it is higher than the mitral annulus, it is a supramitral ring. And when it is higher than the left atrial appendage, it is a core triatrium. It's another congenital anomaly. Okay, and we can see that 3D echo would give us a better visualization of all these anomalies. Okay, here we can also see the core triatrium and the supramitral ring. differentiate between both of them. Shunt complex. What is shunt complex? It is an association of different anomalies, and the most important, it's the supravalvular mitral ring. We can have a parachute mitral valve that we're gonna discuss later, a subvalvular aortic stenosis, and aortic coarctation. Okay, here we can see aortic coarctation. We have a patient here with a parachute mitral valve and a single papillary muscle. And here we can see the ring. So in mitral stenosis, what we can see, commissural fusions like in rheumatic, we can see hammock valve, we can see parachute valve and funnel-shaped valve. Rheumatic, as we said before, we have a commissural fusion. On transthoracic echo, it is like a fish mouth appearance. And you can see here leaflet thickening, which is mostly pronounced at the tips, giving a characteristic of hockey stick appearance of the mitral valve. The double orifice mitral valve, it's a very important, it's a very interesting anomaly. It's a rare congenital anomaly, and it may be coincidentally diagnosed on echo. It is rarely, it occurs as an isolated anomaly. Normally, it is associated with a variety of other cardiac anomalies and mostly with an AV canal. So it is a heart anomaly. You can see here the double orifice. We have several categories of the double orifice mitral valve. We have the congenital native one. Okay, with this anomaly, mostly if you look here closely, you can see that we have asymmetrical orifice. Okay, one orifice, one medial orifice, which is very large, and one other lateral orifice, which is smaller. This will say that it is a congenital anomaly of a double orifice mitral valve. If you can see the other ones, the other categories, we have the acquired native valve. That is, with age, we have calcification. And then you have calcification, we have a fusion of A2 and P2. With fusion of A2 and PP2, this will create a double orifice. Okay, it's something like a double orifice mitral valve, but it is not a true double orifice mitral valve. And sometimes with surgical procedures like the Alfieri stitch for mitral regurgitation, we can create a double orifice mitral valve. And even with the adult population nowadays, with percutaneous mitral clip procedures, okay, when clipping the mitral valve to decrease the regurgitation, we can have this shape of the double orifice mitral valve post-mitral clip. Then we're gonna discuss the mitral annular hypoplasia. It's a rare congenital mitral valve malformation characterized by hypoplastic annulus, which usually appear within a complete mitral valve hypoplasia, causing mitral valve stenosis. It is most commonly associated with a hypoplastic left heart syndrome and also other cardiac malformation. For the subvalvular type, now we're gonna talk about the parachute mitral valve. In parachute mitral valve, here you can see a single papillary muscle, which is, and we can see the chordae tendinae related to this only single papillary muscle. We have a embryological problem in the fusion of the papillary muscles. Okay. So we have two types of parachute mitral valve: a true type and a parachute-like mitral asymmetry. In the true type, we have an embryological failure in the separation of the papillary muscle. So we will have a single papillary muscle with thickened and shortened chordae tethered to the single papillary origin, could be associated with mitral regurgitation. And for the parachute-like mitral asymmetry, the anterolateral muscle is undeveloped and short. Okay, so if you can see here, this is the true one with a single papillary muscle. This is the anterolateral, which is short and underdeveloped. Okay, which is not a true parachute mitral valve. Here, this is a patient with a parachute mitral valve and LVOT obstruction. You can see here a single papillary muscle. So this is the case. We can see the apparatus of the mitral valve obstructing the LVOT, as we see here, with aliasing. The single papillary muscle with the parachute mitral valve. Okay, so this is the one and only with the fused, which is one papillary muscle. The hammock mitral valve, which is characterized by underdeveloped or absent chordae tendineae, abnormally hypertrophic papillary muscle, reaching their tips just underneath the leaflet, resulting in mitral stenosis, regurgitation, or both. You can see here the second papillary muscle, okay, and the area of the mitral valve, which is small area. So here we have the types we talked about. This is the normal anatomy. This is the asymmetric mitral valve. This is the parachute mitral valve, and this is the hammock. Okay. So for the asymmetrical one, we can do here a commissurotomy. Okay. Then we can split the papillary muscle here. Okay. For the parachute mitral valve, we can see, if you see here, you have the line here, the line of the commissures, okay? And this is a commissurotomy here. They open the line and the incision of the papillary muscle and splitting of the papillary muscle to open the valve, okay? For the hammock type, you are showing here the anterior and posterior leaflet, mitral leaflet, with chordae inserting directly into the LV posterior wall. It is directly inserted in the LV posterior wall. We do a line incision of the posterior LV wall, and we will have a new papillary muscle curved off the posterior LV wall. We can see here the new anatomy. And as we said, we have sometimes an association with LVOT obstruction, and we have a systolic anterior motion in case of hypertrophic obstructive cardiomyopathy. Here we can see the systolic anterior motion on M mode and the gradient with a dagger shape, okay? And sometimes we have a mitral regurgitation due to the SAM. So the Carpentier classification for congenital mitral stenosis, it is classified in two groups: the normal papillary muscle and the abnormal papillary muscle. With the group of the normal papillary muscle, we have the commissural and papillary fusion. We have excessive leaflet tissue, valvular link, and annular hypoplasia. And for the abnormal papillary muscle, we have the parachute and the hammock mitral valve. For mitral regurgitation, also we have three groups, three categories. First, we have a problem in the annulus, a problem in the dilatation of the annulus, secondary to ventricular dilatation, could be due to endocardial fibroelastosis, ischemia, infarction, ASD. And secondly, we have the leaflets, a problem in the leaflets, cleft in the leaflets, leaflet defect, mitral valve prolapse with rupture and elongated chordae tendineae, congenital perforation or displacement, Epstein anomaly of the mitral valve, which is very, 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 very rare, and duplication of the orifice like we saw before, and bridge for the subvalvular apparatus, bridge of the fibrous tissue, anomalous arcade, and shortened chordae tendineae and abnormal papillary muscle. So this is in case of ischemia. We have functional mitral regurgitation with tethered mitral valve and papillary muscle displacement. Mitral cleft. For mitral cleft, it is due to congenital mitral hypoplasia. This condition may be present with or without other congenital heart defects. A cleft that is not associated with a septal defect is defined as an isolated mitral valve cleft. So here we need to differentiate something between indentation and cleft. The indentation, when you have a groove which is less than 50% of the leaflet, and for the cleft, it is more than 50% of the leaflet. And you can see several clefts in the images. So isolated cleft is more prevalent than we know, and it is with 3D echo we can have a better image of the clefts. We can see them better. The majority of isolated clefts are located on the anterior mitral valve leaflet. Patients with isolated cleft on the anterior mitral valve tend to have more mitral regurgitation. And it is important to diagnose cleft, because if it is not diagnosed, we could convert a patient in need of a repair to a replacement, and this will have a higher risk of mortality. Okay, this is so mitral cleft of the anterior mitral leaflet. And the indication for surgery in case of cleft, it is mostly when we have a severity of associated lesions. The severity of the associated lesions with cleft will give us an idea to go for surgery or not. Okay. Of course, the severity of the mitral regurgitation will come in second place. Okay. Mitral valve prolapse. There is several etiologies of mitral valve prolapse, going from the Marfan syndrome, which is the most common, Ehlers-Danlos syndrome, other interesting syndromes, going to the skeletal abnormalities, the pectus excavatum, and other anomalies, the hypertrophic cardiomyopathy. Okay, so here you can see a mitral valve prolapse with a mitral valve disjunction, okay, and a severe mitral regurgitation. This is a case I saw today. This is a patient diagnosed at 12 years old having a Barlow disease. You can see here the prolapse and the mitral disjunction. You can see here the disjunction, and this is her regurgitation. She has a small pericardial effusion because she had COVID 3 months ago. Okay, so for the mitral valve prolapse, when it is localized in P2, for example, we can resect the area and do application suture, okay, then a annuloplasty. When it is excessive tissue, like the Barlow disease we saw before, we have to resect all the area and do the surgery. This is a P2 rupture. Also, can see here the prolapse. And inhibition anomaly of the mitral valve. Normally, I didn't saw any of these cases, and it is very rare. So the Carpentier classification for the mitral regurgitation, congenital mitral regurgitation, it is classified in 3 types: the normal motion of the leaflets, the prolapse of the leaflets, and the restricted motion of the leaflets. Normal motion, deformation and dilatation, clefts, partial agenesis, and prolapse of the leaflets, absence of tendinous cords, elongation of tendinous cords, and elongation of papillary muscle. For the restricted motion, we have 2 cases. In normal papillary muscle, we have commissural fusion in rheumatic, shortness of cords, and in abnormal papillary muscle, parachute mitral valve, hammock, hypoplasia of papillary muscle, Epstein anomaly, double orifice, and we talked about all this. One word about the rheumatic valve disease, which is also a very important etiology. You can see the commissural fusion, the leaflet thickening, and the chordal shortening and diffusion, and superimposed calcification, of course, with age. Okay. Here we have a case with mitral stenosis and commissural fusion. Then here in B, you can see a unicommissural opening after a balloon mitral commissurotomy. Then here we can see opening of both commissures after balloon mitral commissurotomy. So as we said, it is in rheumatic mitral valve disease, we can find the fusion, the early diastolic doming motion of the anterior mitral leaflet, which is the stick hockey stick appearance, and the calcification, the chordae shortening and diffusion. And this on M mode, okay, on M mode you can here find an anterior motion or immobility of the posterior mitral leaflet. You can see it here, okay. So the operative procedures for mitral valve in these cases, for mitral regurgitation, we have eccentric annuloplasty, ring annuloplasty, leaflet plication and chordal shortening, suture of cleft, and valve replacement. For mitral stenosis, resection of the supravalvular ring that we saw before, open commissurotomy and splitting, correction of a parachute deformity, and valve replacement. So finally, you need to differentiate your etiology to see, is it a rheumatic, is it a congenital mitral stenosis? And thank you for your attention.
Thank you, Dr. Randa. محاضرة جميلة جدا. تسلم ايدك.
Thank you. Is there, if you have any questions?
أنا عندي question. الميترال فالف prolapse ازاي نفرق هو روماتيك أو ولا congenital من الإيكو بعيد عن الهيستوري وكده؟
Mitral valve prolapse. Can you repeat your question? I didn't hear.
Mitral valve prolapse from echo, either it's congenital or rheumatic. How to differentiate by echo?
Most commonly, it is congenital. It's not rheumatic. Mitral valve prolapse.
Some patients with rheumatic heart disease have what like mitral valve prolapse as a complication of rheumatic
as an association, if you want. It could be associated. Then you will have a thickening of the valve.
Yeah.
Mostly you will have a thickening of the valve, yes. When you have a rheumatic disease, you need to have not only one valve which is affected, you will have more than one valve affected normally.
Some patients have mitral first, then aortic. So we can catch him while having mitral regurg only. If he is diagnosed in early diagnosed in pediatric patients, he may have mitral first, then aortic.
I didn't get your question.
In pediatric patients, some patients with rheumatic heart disease, the mitral valve is affected early, then the aortic valve.
Yes.
So we may diagnose the patient while he has only mitral regurg.
Yes.
So if we see a patient with mitral regurg and he has history suspected rheumatic fever, we can say that this valve is affected by rheumatic fever or he has congenital mitral prolapse. By the appearance of the valve.
You need to see the appearance of the valve. You will have the prolapse. You saw the aspect I gave you before. Let me go to the slide. I can try to go to the slide. Sorry.
What I do, I think in rheumatic fever, the valve should be beaded and thickened. Is it true?
Should be what?
Beaded and thickened. Should be thickness in the tips and
yes, of course. It has to be thickened. The valve has to be thickened.
So if the patient has mitral valve prolapse without thickening, sure he's not due to rheumatic.
Look at this case. This is a patient who have mitral valve prolapse since 12 years old. Okay, I saw her today. She's at 30 years. Okay, she has this prolapse. She doesn't have this thickness, but she has excessive tissue more. When you see it is excessive tissue and you see both leaflets are having prolapse, it is more a prolapse due to Barlow disease. You saw here this one. Here you have this excessive tissue, okay? Any other questions?
في أسئلة تانية يا جماعة؟ I have another question. If there's a patient with mitral valve replacement or aortic valve replacement, and she's on Marivan, and the patient become pregnant, she's other patient, what will you do?
And she is on?
Marivan.
What?
Anticoagulation.
She's on anticoagulation.
Yeah.
Like on Coumadin, you mean?
Yeah. And now the patient is pregnant.
Yes. So you need first you can continue anticoagulation. Then you can stop you have to stop anticoagulation and put her on enoxaparin, on Lovenox.
This is a question: at which number it is considered 6? What do you mean by number? I think the question
more than 3 to 4 millimeters. It is thick, yeah. If you want to measure it, more than 3 to 4 millimeters.
Are there any other question؟ في أسئلة تانية؟ Okay, I have another question. Here in Egypt, with adult cardiologists, I think they overestimate mitral valve prolapse diagnosis. All females here with who do echo are diagnosed as mitral valve prolapse. What's the definite diagnosis of mitral valve prolapse by echo? What's the definite signs or sure signs by echo?
Different signs of mitral valve prolapse by echo?
Yes. Here, all female between 20 or 30 years old are diagnosed as mitral valve prolapse.
And yes, this is not, you have sometimes a billowing of the valve. They describe it as a prolapse, which is not true. When you have when you have the valve that goes in the left atrium, but in a small way, this is a billowing of the valve. We describe it. Sometimes you will have a very small, a very trivial mitral regurgitation. They sometimes describe it as prolapse, which is not true.
Yeah, I think they diagnose any kink in the valve in the left leg as prolapse. Any arming.
Yes, it is very common.
It's very common here.
Yes, even here, even in Lebanon.
دكتور محمد صلاح السؤال about mitral valve prolapse. السؤال. في سؤال من دكتور أيمن. Rheumatic heart disease can affect aortic valve without mitral valve?
Yes. Sometimes you can have this, but it is rare. Most cases you will have it will affect both of them. Okay, but in different severity. But sometimes you can it will affect the aortic valve sometimes without affecting the mitral. It's a case by case decision diagnosis.
يا جماعة في أسئلة تانية؟ Another question? Thank you دكتور رندا. محاضرة جميلة جدا. It was very interesting. كلنا استفدنا منها جدا.
Thank you so much for all of you.
And we are waiting the other lecture إن شاء الله. Aortic valve disease.
Okay. Thank you.
Thank you very much. شكرا يا جماعة على استماعكم، وإن شاء الله بقية المحاضرة تبقى يوم الجمعة الجاية. محاضرة aortic valve disease مع دكتور رندا مشكور. شكرا.